will be a long-term correction of the basic root problem rather than just doing teaching the skill which they are not able to do. So because 20% of all children have the issue, so they do better in home-based environment with familiar circumstances rather than struggling in a normal school. So in the normal school, if it integrates with the center and the home, then it will do wonders. Learning is by seeing, hearing, and touching. So they may be equally balanced, or child may have preferences. Most of us have equally balanced, but 20% children may have preferences. A child with Down syndrome and say other thing can be slow learner with global delay, but their processing is altered. It is not slow, but it is altered in autism. They may process very fast, but it is altered. So root cause also based is based intervention. We are planning in this module. They're working on attention span, anxiety of strangers, and anxiety of separation, which is particular to children, and slow processing. Then not talk much about IQ. It can be different severity, mild, moderate, severe, profound learning disability. So for example, if we plan, this is one of the last slides, we plan the weakness of the child, strength of the child, that his visual learning is better, behavior and confidence build up. For example, dyslexia, we give a severity score, that your child is there in this much severity in different parts of dyslexia, behavior. We assess the stress of parents and also help the sleep issues. Then the treatment is planned in a home school center-based environment. Here we are saying a home environment is better. Now here when we integrate the a structured program at a school for particular need of the particular child, then these three together, because learning happens, intervention happens in between the sessions. Half an hour session is done at the center or 1 hour session. Then the things are done at home environment and at school environment. The next session, the child comes. So intervention learning is between the sessions, and then we refer the test videos from which the child learns, and parents assist the child because the parents are the best teacher. And so here I would say so here I would say the assessment is after 2 months, so that we see the progress. So this is the last slide, that with 2,000 pediatricians in Uttar Pradesh for 10 crore children of Uttar Pradesh. Now, under 5 children can be 1/4 of this, but all children of all ages, like less than 5 years children, there are 50 lakh of them will be having learning disability, and over 2 crore children of all ages, they may be having behavioral disorders. And mostly mild if they are picked initially, so we need to screen. So who has to address them if not pediatrician? Because we have already 2,000 only. So from where we can bring so many pediatric neurologists? So yes, is it the domain of primary pediatrician with unhurried approach and can help them to adjust well in society to help these children. How it can be done? Is it possible? My next colleague, Dr. Arvind Taneja, Dr. Sunil Taneja ji, he will tell us more on how it can be done, how he has done it. Thank you very much for patient hearing.
Thank you, sir, so much. Thank you so much for lucid talk. And our second speaker is Dr. Sunil Taneja. Dr. Sunil Taneja graduated from the Wardha Medical College in 1979, and post-graduation he has done from GSVM Medical College in 1983. He has got short-term training in neurology in 1986 from PGI Chandigarh. Sir has been very active in his district branch of IAP. He has been president and secretary of Kanpur IAP and president scientific secretary and vice president of IMA Kanpur in 2009, 10 and 11 and 12 respectively. So he is the founder, member and consultant to the Hemophilia Society Kanpur, and he is the managing trustee and consultant to the Spastic Center named is Ashaye Kanpur for differently able children. And sir has done fellowship in pediatric neurology from the UK in way back in 2015. Sir is very active and neurodisability is at his core of practice. Thank you so much for joining, sir. Sunil Taneja, sir, over to you.
Can you hear me, Dr. Yadav? Thank you for your nice comments. So I will now start my presentation. I'm
Yes,
sharing.
sir.
Okay.
Please start.
Both of us have gone through the same training. The lessons I have learned, how they are different by different learner, Dr. Taneja. So one of the busiest pediatricians, all of them came into 2017, our conference, and like leading pediatricians from all over the state, Dr. Ravi Khanna from Bareilly, Dr. Taneja, and people from different parts of the state. So how a busy pediatrician can do the things, this we can learn from Dr. Taneja. Dr. Rahul, you can stop my host so that he can, Dr. Taneja can. Is there Yes.
Sorry, it took taking a little time, but it's now almost ready. So I will briefly just elaborate more on what Dr. Sanjay Niranjan has very eloquently talked. In the course of my talk, I will be just highlighting something about the definition of neurodisability, what is the degree of problem, and how we can approach, and my experience about this. So, so the next slide, this is my short introduction. So neurodisability describes a group of congenital or acquired long-term conditions that are attributed to impairment of the brain or neuromuscular system and create functional limitations. A specific diagnosis may not be identified. Conditions may vary over time, occur alone or in combination, and include a broad range of severity and complexity. The impact of these may include difficulties in movement, cognition, hearing, vision, communication, emotion, and behavior. And what is the scope of problem? It's a huge problem. Even in the Western world, 1 in 500 children has cerebral palsy. 1 to 2 per 100 children has autism spectrum disorder, and 1 in 20 children has developmental coordination disorder. So these are the three basic or the crux of the neurodisability problems. And the tragedy is that 80% of the children with disabilities live in resource poor settings. So it is likely that there is a higher prevalence of cerebral palsy and neurological impairment in these settings. However, exact data is not available. Whatever is available shows that neurodisability in 2 to 9 years ranges between 82 to 160, and neurological impairment varies between 19 to 61. The rates of cerebral palsy in India and China are approximately the same as in the Western world. So with this huge problem, and especially with the fact that we are staying in a country where resources are not adequate, how do we go forward to tackle this issue? So the problem is that there is dearth of trained developmental pediatricians, pediatric neurologists. There's lack of paramedical staff. There is, of course, as you all realize, that these kind of things, the money earning potential is less. So there is lack of interest in young professionals. Most people want to go for NICUs, pediatric cardiology, where there is ready cash, there is ready reward. Here, the reward is not so evident most of the time. So what's the way forward? The way forward, I feel, is that we should train interested pediatricians to identify developmental issues, identify neurodisability correctly along with their comorbidities. Teach them the best treatment guidelines, network these professionals, and provide online support. So I'll just take up these issues gradually and give you some examples of how we can go forward. See, after getting a short-term training from the Genius Lane and Dr. Rahul, Bharat especially, so I started a child developmental clinic in my own center, and this is the logo which I designed, which I of course designed, and this is how I go about. So my suggestion to my pediatric colleagues is that in your own clinic, earmark some time for developmental issues, pediatric neurology. Associate a child psychologist, audiologist, and preferably, if possible, an orthopedic surgeon with you. Use MChat for screening any child between ages of 1.5 to 2.5 with speech delay. This is very important because every child, the incidence of autism is so high that unless you are proactive, we will be missing out. And even the American Academy and there are various other professional bodies recommend MChat screening as a routine in all children. So this is the age where when the child comes for the 1.5 year vaccination, we should always ask a question: is how's your child's speech? How's he doing? And any negative remark from the parent should prompt us to go for this, and take help, of course, from experts for troubleshooting. So I'll give you two examples of how I was able to solve two problems after getting this training from Dr. Rahul, Bharat and his team. So do you all know that why infants with dystonia cry excessively? This was a question which was put forward when we were being trained. So I didn't know the answer. I was told that because they're experiencing pain. And if you add gabapentin to trifenoxidil and clonazepam, it gives excellent results. So I tried this in few patients. I was really happy because I never knew that I used to keep on increasing the sedation. I just thought that I never realized that they are having pain, and gabapentin could be a good drug. So this is one small intervention which can make the children happy, the parents well satisfied. Because many times when we see children with gross motor disability, we are at our wits' end at what to do, except for giving some kind words of consolation. Then I'd like to share another case. There was a 3-year-old male child who presented with gross motor delay. Only head control was present. There were no contractures, social milestones, and speech were normal. MRI, metabolic workup, NCV, EMG, genetic workup for SMA, all were normal. He was carrying loads of reports, many pediatric neurologists. There was no relief. So what was the diagnosis? I was not very sure, but I just thought, let me try levodopa. And there is a condition known as dopamine sensitive dystonia. This patient came back to me 3 months later. The child was walking. A child who was unable to have a proper neck holding if he comes to you with 1 tablet of levodopa, and the dose I had given was half tablet 2 times. So he came back, the father said that, I said, how's your child doing? He says, okay, you can have a look. Only thing he says that, Dr. Saab, your medicine was, it was effective, but the dose was less. I said, how? He said, when I gave it 3 times, my child is perfectly all right for all the 24 hours. When I give your dose, he is only all right for about 12 hours. So I now give it 3 times. So, I'm just thinking that once this corona gets over, I'll send him to school. So some of these interventions, you can do, and these can be life-changing. They make you feel happy that how much, some small tip or some small learning. And all this is because what we have learned is that you should always try and correlate the clinical picture with the investigative findings. Suppose you're not getting anything in the MRI, the child is having a gross problem. So think there has to be some cause. So one of these, can be this dopamine sensitive dystonia. So try this. It's not going to cost much money. If it works, it's fine. So my last slide. So what is a take-home message? Short training, online or offline, can sensitize pediatricians. Developmental clinics can be integrated in pediatric clinics. Certification of pediatricians and digital record keeping will improve quality. I acknowledge the role played by Dr. Rahul Bharat for giving a new insight to pediatric neurology, where problem solving becomes an enjoyable experience. And thank you all the listeners, and I hope all of you will start and do something for which this conference is going on, and we will move forward. Thank you, Dr. Yadav, and thank you, everyone. This is all I want to say.
Thank you, sir. Thank you so much for a nice experience. And I have been also the part of this training module, and really it works magic. There is so simple tips to identify the lesions in the MRI, simple way to how to identify the EEGs. Really great training module. Thank you, sir, for your nice experience. Now the next speaker is Dr. Alka Agarwal, ma'am. Alka Agarwal, ma'am, is the visionary president of UP-IAP, and she is the Dean Santosh Medical College. Ma'am received fellowship in IAP in 2013, and ma'am is joint national coordinator of NRP since 2015. Ma'am is faculty also in the NRP. She is the state academic coordinator of Child Disability Chapter of IAP 2013, and ma'am has been the national faculty in various programs of Central IAP Life, all about fever, United Airways, EPID, RNTCP, and Mission Uday. Welcome, ma'am, and we would like to listen from you about the mission and vision of UP-IAP about the neurodisability. Over to you, ma'am.
Thank you very much, Dr. Yadav, for the nice words. And I bring greetings from Academy of Paediatrics, Uttar Pradesh, and I represent here as president. And being a developmental pediatrician myself, I'm quite aware of the challenges of the patients, children themselves who are suffering, of the parents who are equally suffering, and at the same time, the caregivers, the doctors, a teamwork of doctors who also sometimes do not have any clue. So, and I thank Dr. Rahul for giving this platform for UP to bring out what the vision for UP state is. I think a lot of it has already been covered by, it's not moving. Just a second. Yeah. So I think I would like to begin with the neuroplasticity, the concept or phenomena of the neuroplasticity, in which because of the axonal sprouting and the synaptic pruning, if there is any damage which happens to the brain early in life, the other part of the brain, the functional part can be taken up, or the brain gets acclimatized to another function. But this happens with the help of synaptic pruning as well as axonal sprouting. And this is how the paths are created, whichever functional damage which has happened, So either there will be, pruning of the synapses, or there would be strengthening of the synapses so that the function of the brain is minimally affected. So having said this, why I used this slide was basically because our focus has to be the early intervention for any neurodisability. What Dr. Niranjan also said, and Dr. Sunil Taneja also said in their experiences also, the early intervention, the earlier diagnosis, as well as the intervention as early as possible in life we can do, the outcomes are always better. And this is where we fare very, very badly. Another thing I want to highlight is that neurodisability, we all know, is a spectrum. It has also been highlighted by Dr. Yadav, by Dr. Niranjan, as well as by Dr. Taneja. It's not a single entity. We have varied conditions, and those conditions also are associated with so many comorbidities, antecedent morbidities, as well as, the spectrum of each and every, even if we say that it is cerebral palsy of one child may be different from the cerebral palsy of the other child. As a result of which, the customized approach or tailor-made approach is needed for all patients. They need a treatment plan, which could be different for one patient from the other. And inclusivity should be the focus. As already discussed, that it is not the caregiver or the doctor alone. It has to be the entire caregiving team, which includes parents, which includes teachers, which includes other people who are taking care of the child at home. So inclusivity has to be the focus in such conditions. Also, as we know that it is a multi-pronged approach which is needed in management. The management itself is very, very challenging, and more so because, the sensitization of the pediatricians is not so much. They are trained in doing the developmental assessment. What beyond that? How to approach beyond that? How to go about giving them instructions or giving them even prognosis becomes very difficult for a general pediatrician himself. He will be able to, sometimes pick up the diagnosis if the sensitization has been improving with a lot of, efforts which are being taken by the government as well as by the central IAP, as a result of which the picking of the diagnosis may sometimes be a little easier. But intervention or where to go for intervention becomes the major challenge. And for that, the many inputs from many modalities are needed, from pediatricians, from occupational therapists, speech therapists, clinical psychologists, and several other departments from which the inputs have to be needed for a collective and a holistic management of such a child. Now, status in Uttar Pradesh. I will just, though Dr. Niranjan discussed about the incidence and the prevalence of the disease, I just want to go about the data which is available from the government census, though it is a little older data because that was when the census in the country was done. The prevalence of all-cause disability, this not only includes neurodisability, includes all-cause disabilities, 1.1% in 0 to 4 years and 1.5% in 5 to 9 years. But the actual estimates which have come from the different studies are actually 10 times higher. This is because of very focused questions that are being discussed in the census, which leaves out a lot of mobility, conditions. And as per a study which was conducted in 2018, the incidence of neurodisability in Indian children under 6 years is approximately 9%. This also is an underestimate, basically because it does not include the behavioral disorders, or it does not include the learning disorders which are prevalent in the children. And I was quite surprised at the figure that Dr. Sanjay gave. It is to the tune of 20%. So if you go by this figure of 9% also, we have somewhere 30 to 50 lakh children in UP alone, which have one or more disability. And these are only rough estimates. Again, we don't have any database of even grading them into mild, moderate, and severe. So in other words, almost 1 in 11 children has at least one of the following impairments. It could be neuromuscular disorders and cerebral palsy, epilepsy, intellectual disability, speech and language disorders, and hearing or vision impairment or autism. And amongst them, actually, what has come out to be maximum is the hearing impairment. Again, these are studies which have come up from multicentric trials, and this includes the entire state, entire country, and UP was one of them. Again, because of the diverse geographical, correlates, because of the diverse epidemiological correlates, because of the educational status, the management could not be made universal depending upon these estimates that I'm projecting. So as with all this background data, the challenges of in UP are immense, and with the burden that I talked about, and with the number of pediatricians, general pediatricians that are available, which is to the tune of 2,000 to 2,500. Even if you consider some Jhola Chhap doctors or certain, MBBS doctors who are practicing pediatrics, the number may go up to 3,000 or 3,500, not more than that. And the non-uniform demography, rural challenges are different, urban challenges are different. The programs, which are initiated, which are initiated at the central level, are become difficult to percolate. The most important challenge is that we do not have any comprehensive data on the developmental pediatricians. There is no database. Another thing is, sometimes the patients, they are doing so much of doctor shopping because they expect something, a favorable prognosis for them. So if any doctor who talks in their language, in the language meaning that they give them a good prognosis, they are all directed towards that doctor, and somebody who may be having more knowledge, or who may be giving them a prognosis which is not to their to a liking to their ears, may not be very well acknowledged. So again, the sensitization of the parents is not there, and they go on to believe in doctor shopping. As a result of which, the interventions, which may be, some of the children do not have any intervention as to age of even up to 8 years or 9 years. That is when their condition is recognized, and that is when their appropriate diagnosis is made. As a result of which, the interventions which are done at that period will definitely not have a very good prognosis, and they will have varied results. So as a result of which, a database is needed, a website is needed, and a digital drive. Certain interventions have already been initiated in the country, and the Ganesh program for children of UP is one of them, which goes into early intervention based on general movements in children, and that would be a good exercise to pick up cerebral palsy early. Then even free apps are available, especially from Paediatric Neuro Department of AIIMS, and they diagnose attention. They have apps for 4 conditions like attention deficit hyperactivity disorder, neuromotor impairments, autistic spectrum disorder, and epilepsy. And a recent advancement has been, thanks to COVID, the telemedicine has been on the rise, as a result of which the treatment plans are being offered through telemedicine. I have not included this Brainrakshak program because this is a very, this is my first experience with the people who are dealing with it. But definitely now that we have associated, the Academy of Paediatrics is associated with this program, this can definitely find, because it is a app-based program, and it can definitely percolate, as I'm told that it has programs for children, for treating physicians, as well as for the parents. So if they are on the same platform, I think the results will definitely be better. And it's quite evident from the study which was projected by Dr. Sanjay Niranjan in our program, and also by the way they have projected the program to be. There is also a Right of Persons with Disability Act, and I'm afraid not many people are aware that under this disability there are a lot of provisions which have been given for schooling and other aspects, including monetary help as well. So the vision for UP is basically early child development module, which has also been launched by CIAP to be percolated in 10 major districts in this year. We are in the process, and this will begin from April. The emphasis is on sensitization and the database on the diagnostic and the treatment centers which are available in each district. We have to explore the digital modules, and definitely Brainrakshak is one, and apps for home-based early intervention, and also to go into the public-private model to develop certain centers in which government as well as the private institutions can together play a part. Thank you very much for giving this platform. And, I've also been sensitized to a lot of what you are doing. Thank you very much.
Thank you, ma'am. Thank you so much for nice words. And we are privileged to be here, and we listen to you carefully. And we hope that you will support this nice cause for neurodisabled children. And now the next talk is by Ms. Shubhi, who is a clinical psychologist, and she has got training from the ACBR and Brainrakshak project for last 7 months. We would like to hear from Shubhi and Falumi. Ms. Shubhi, please share your slides.
Just 1 second.
There is a poll that do we need general pediatrician to take lead in neurodisability conditions? And in this poll, almost 88% is agree that yes, general pediatricians should take lead in neurodisability conditions.
Thank you so much, Dr. Yadav. And first of all, I would like to thank Dr. Bharat and Dr. Osena for giving me this opportunity, and as well as Dr. Yadav for always acting as a motivating force at every step. So a very warm afternoon to one and all present here. I would like to begin with a quote by a famous American author, which states that the capacity to learn is a gift, the ability to learn is a skill, and the willingness to learn is a choice. So now, as one grows in his lifetime, he keeps on gaining various experiences at every milestone of his life. And this forms the backbone of an individual's learning. And today on this platform, I would like to share that how significant it is to incorporate our applied knowledge to our system. That is, it is not just the theoretical knowledge which builds onto the learning foundation, but also the practical exposure in addition to this knowledge, which strengthens our capacity. Now, studying psychology, like it is very different from practicing it in reality. So, okay, let's see. Okay. So before starting and moving further with my presentation, I would like to state that I'm working at Genius Lane as an assessor, and it is my truthful and honest experience that I'm going to share, and it won't be the promotion of any product. Okay. So yes, as I stated, that studying psychology is very different from practicing it in reality. It's basically that psychology is not just the study of structure or function of mind, but it is combining the three forces, which is the behavior, the cognition, as well as the emotion. And like further moving on to one's learning at Genius Lane, which is the part of Child Development Center, an individual not only learns to work with the client, but also builds upon one's soft skills, such as communication, which is very necessary for smooth functioning of any organization, as well as at a personal level. Working here has led one to gain in-depth understanding about the various neurodisabilities, the main problems in that particular diagnosis, and the intricacies that are needed to be kept in mind while observing a patient. Now, the 6 areas or the diagnosis that we majorly work with are autism spectrum disorder, global developmental delay, cerebral palsy, intellectual disability, developmental coordination disorder, and dyslexia. And understanding the diagnosis, the main problems, and the importance of result that is there, it's very important. The organization works on the principles of early intervention with children with above mentioned diagnoses. So early intervention has served to be a very significant practice while working with children with non-progressive neurodisabilities, as a baby's brain is developing till 6 years of age, and early intervention at an early stage would promote his, preserve and nourish the child's brain and promote his brain environment. So it would also strengthen the child's early foundation skills as well as his day-to-day functioning by understanding the basis of a child's adjustment in later life. So basically, the focus of the result is improving the quality of life of an individual. Further, moving on to the, now let's bring our attention to certain key points here, which is the IBAC platform, the importance of early intervention, importance of child-led and home environment, importance of understanding the diagnosis and its result, stages of grief and providing to support to the family through counseling process, and setting the collaborative goals. Now, further moving on to the IBAC platform, which stands for Intervention Based on Assessment, it is the first ever such digitalized platform in the world, working on the principles of developmental and applied behavior analysis, and not just the applied behavior analysis. So it will be further covered by Dr. Bharat in the conference. Now, the entire program that we work upon is child-led, as we try to understand that where the child is developmentally and the intervention that needs to be incorporated depending on the developmental needs of that child. So it helps us to, this program helps us to reach our next goal. For example, if the child is at 3 years of age chronologically, but his understanding is at 12 months, so what should be our next goal in this program? So this platform helps us to prepare our next step in this early intervention program. So now let's talk about the stages of grief. So what are these stages of grief? Now, first of all, let's talk about the 5 stages. What is denial? So basically, initially when the parents come with their children to the center, so when they are diagnosed with a certain particular diagnosis by the doctor, by the pediatrician, so they enter a stage of denial. And this feeling of numbness is very common because then they are not able to cope with it. And they carry on with it as if everything is all right with them. So they would say, if you ask them about the diagnosis or the result, then they would say that yes, the doctor had mentioned about this thing, or everything is all right, it's gonna get better with time. And then we further move to anger, where they start blaming each other, the parents start blaming each other, or they enter into a conflict mode. The third stage of grief is bargaining, where bargaining is basically when we are in so much pain that it becomes very hard for us to accept that, okay, there is nothing that we can do about a certain thing. So there we start to make deal with ourselves through like rationalization. For example, a child which has been diagnosed with autism spectrum disorder, so the parent would often try to focus on the specific skill of the child. For example, they would their major result is not making the child independent, but the major focus is on like the speech of the child improves. So it becomes very hard for them to accept. Then we move on to depression, and then gradually when their pain eases and they are ready to accept, that's where we try to see the reduction in their stress level, and that's where we can make the program more beneficial for the child. So basically, IBAC helps us to identify the exact stage of grief in parents. Like we have been trained to look at the graph and find out as to get a deeper understanding and meaning of what parents are trying to convey. And everything is basically data driven. So we can actually, through this IBAC platform, we are able to understand the actual state of grief in parents, and the structure that needs to be improved, or the routine that needs to be improved while working with the children with neurodisabilities. Because as we see that parents often tend to set their own goals and focus on more on setting the skills of the child rather focusing on a bigger picture. Therefore, here the parental stress index plays a major role. And as we see that improvement in parental stress index leads to improvement in their children. So through the graph also we can find out, for example, if the severity score of the child has increased, but the parental stress of index of the child of the parents is still less, so we can find out that okay, they are in denial. And that's how we gradually move, by supporting them through counseling, through empathizing and understanding their actual internal frame of reference as to where the parents are at current stage. So the platform enables us to understand the home environment of the child. And by getting an idea as to whether the child is receiving an adequate home environment and support that would nourish his holistic development. Now, as we all understand that a child doesn't come alone, but in a package, that is himself, his family, teachers, and school management. Therefore, it is very necessary that the system which is working around the child is at the same pace with the child, and that the interaction should be child-led, as it allows the team to work strategically towards understanding the development and promote the child's brain growth. So through this entire Brainrakshak project, let's focus on more comprehensive and collaborative growth and reach out to more families who need help. And that is how I would like to conclude my presentation by saying the quote, which is that if I cannot learn the way you teach, then teach me the way I learn. Thank you so much for your patience with me.
Thank
Thank you,
you,
sir.
Shubhi. Thank you for your experience and nice experience. And there is very comprehensive approach of Brainrakshak to understand the neurodisability and to understanding this problem in whole scenario, incorporating the parents, their stress, their inner phase, and dealing with all the phases. Thank you so much. And we have another ACVR intern, Palomi Kurade. She will share her experience.
Good afternoon, everyone. I'm Palomi Mangesh Kurade, and I interned as a research assistant at the Association of Child Brain Research. My research duties mainly comprised of researching in the field of scoping review for children with autism spectrum disorders. We worked on a research project that would scope the entire literature available on the availability of eHealth apps, that is mobile health apps for to support parents of children with ASD. Through this research project, I learned about various terms of scoping reviews, such as the population concept and context, PCC, and I learned the complete process of how to conduct a scoping review. Dr. Ozana has been a huge help, as she was my mentor throughout. She was very patient in clearing all of my doubts and gave me a detailed explanation of each and everything that I had to do. Over the 6-month period, my critical reading and analytical writing skills developed a lot. I developed a deep interest in studying about the autism spectrum disorders and understanding how it mainly affects parents. Since this has been not been much looked into, often we only focus on the children directly or the people with the specific diagnosis. However, parents play a major role, as they require a lot of support in helping their children go through everything and helping them enhance their behaviors too. My internship project was it was a successful one, and I'm looking forward to enroll in more research internships and research assistant positions, as this one has given me all of the holistic development and information that I require to put myself in the field. Thank you.
Thank you, Dr. Kurane. And there is a poll: do we need a team of psychologists and pediatricians in clinics to address neurodevelopmental problems? And in this poll, almost 93% agreed that there must be a psychologist in the clinics of pediatrician to deal with the neurodevelopmental problem. In this way, we have a very nice experience from the Brainrakshak project as well as from BCBR. Now I would like to invite Dr. Rahul Bharat, who is the next speaker, and a short introduction of Dr. Rahul. Dr. Rahul has got MBBS from India and MRC PCH and FRC PCH from the Hillingdon Hospital Child Development Center, Central and Northwest London NHS Trust. He is the consultant community pediatrician, lead neurodisability and epilepsy expert, pediatric neurology and epilepsy, SPIN, Edenbrook Hospital, Cambridge in 2010 to 13. He is the NHS clinical entrepreneur, clinical safety officer, founder of iSpectrum UK and Brainrakshak project in India. Welcome, Dr. Rahul. Over to you.
Thank you, Dr. Yadav. Am I audible?
Yeah.
Okay, so thank you for the invitation. And so I'm going to talk about best practice in pediatric neurodisability. And a bit about me. Dr. Yadav already said that I have interest and work in India, and I've been working in UK and India both for many years now. And I founded the Brainrakshak project and all the training programs, and also I lead similar projects in the UK, NHS clinical entrepreneur. So what is the best practice in neurodisability? So in one line, there is no agreed best practice in neurodisability. Everybody, everywhere in the world is doing what they believe is right for the child. So how can we develop best practice? So let's look at a successful model and learn from it to say, okay, so the successful model I see is Amazon. So I say, fine, you go on Amazon, you are a buyer, you want to buy something, it should be very simple. And you buy, and then an order is generated, and there is a standard operating procedure that step 1 is this, step 2 is this, step 3 is this, step 4 is this. And then there is a procedure to look out for any shortcomings and mistakes, and somebody sitting somewhere is collecting that data and improving the system. So why is the health sector behind and not learning from a system that we can develop? So this is an IBM model. It's one of the best processors makers, and all the system have got task, content, a workflow system, a capture system, and decision-making system based on data. Despite having a rich data for children and problems, and we all know, and we all are aware of the problems, despite that, we do not have a standard operating procedure or the best practice. So how do we reach a best practice? So first of all, identification of problems. And I believe that in the last 10 years or so, we all have become really good in identification of conditions like autism or cerebral palsy. So that has been done. And then evaluation, I think that's also good. We can improve on that. And the whole purpose of Brainrakshak project is to improve on the evaluation. So children only get appropriate test, appropriate information is given, and parents' questions are answered scientifically. People are listening to them. And then we have a solution in which we are looking at the milestones and activities, and a solution which is data-driven. We need a solution which is auto-correcting itself and which is really have the child at the core of it. So how should a best practice be? So the identification should be more in terms of improving our general pediatric training, our training for medical students or MD doctors, so they know how to identify these things. They're very simple to identify. It's just we need to provide them in a simple way. And then the school should know. So instead of having a system to not have these children in mainstream school, the school should have a system to identify them, to help them in their education, have a holistic system, and make themselves compliant with the Indian Education Act. And the parents and grandparents, I see a big role of parents and grandparents, because often they are told, yeah, everything will be okay. And I, so many children and parents I meet, and they said, yes, they were told that with time, everything will be okay. So, and nothing gets okay. So identification in the right way is really important. And then who has the job for evaluation? So if a doctor is doing the vaccines and if they're tuned for it, yes, they can do evaluation for simple things. They can make a diagnosis. They can have collaboration with psychologists for invisible disabilities like autism and stuff, and do that in their clinics. And some of them, like progressive or regressive, they should have a system to refer to a pediatric neurologist. And it should not be that if somebody has got the funds, they can straight go to a pediatric neurologist, and somebody who hasn't got the fund will not reach it. So what we need to change is the system in which child goes to the right clinician and gets the right information, right evaluation, right diagnosis. We should avoid unnecessary scans, unnecessary EEGs, because that increases problems for the child. Cost is not cost effective and causes anxiety in parents. I've seen so many children with abnormal EEG but no epilepsy, and the parents are worried about it, but the main problem is something else. Treatment. A lot of the time, there's no cure for neurodisability, and it's very harsh, but it's important to remember that these are lifelong problems, and children and families will be living with it for the rest of their life. As there's no cure, the treatment should start straight away. And the treatment starts with information, the right information, that what is the problem? Why is this a problem? I see so many parents blaming themselves that, oh, maybe we got more phone during COVID, or child was watching too much phone or whatever. They're blaming themselves. There is internal conflict in the families. There is more divorce happening because of this. So all of this needs to be addressed. So we have stronger families. So we have these families working together to help children. And help to the child. How do we help the child? That's something I'll cover today. Help to the parents. Actually, you can help the parents to help the child. An outcome measure should be done. So like, there cannot be one outcome measure for every diagnosis. For different diagnoses, there are different problems, and the outcome measures needs to be defined. And it's all about having a system to have an outcome measure and having a feedback system which can go back and provide new information to the doctors, to the parents, and system. That's how it will be a robust system, and that will make the best practice. So let's take an example of autism. So we feel that, okay, if we are in a developing country, we have more problems, but that's not true. We have a very good social setup and a support network, and we can use this at our advantage. Let's talk about Europe. So the data from London School of Economics and Political Science shows that the cost treatment of autism is more costly than a combination of cardiac, lung, and liver disease. And the total spending for autism is 180 billion euros per year, which is more than the economy of many countries. So this is how much costly autism is if it is not managed at an early stage or at an early age. So this is just a slide to show that what's happened in the UK. So if a child has got a neurodisability, there is programs for parental understanding, which are run by the local council. And you can see lots of lines. So a child has neurodisability, the school will do something, the local council will do something. If they're not doing it, the social services are there. There is community pediatric neurodisability services, there's therapy services, there is CAM services. They are slow because there are too many branches, but they're still connected. So when we come to India and see what's happening in India. So this is the Indian system, which we can change. And that's why the pediatricians needs to come in. So if a child has neurodisability, they might see a neurodisability pediatrician or a developmental pediatrician, or they might straight away go to a therapy center, or might see a pediatrician on their way. They might get information about the problems which are going to come in a few years' time and what they can do about it. or they might not. And there are independent therapies, there are behavior support, there's special school. None of them are communicating with each other. And then we have government practices, but they're not able to reach the people in a way that they should be reaching. So there's a lot of work to be done, and digital is the way. By having a digital process, we can do that by coming together, by agreeing on a common guidelines and platforms. So let's talk about autism. So when I see children with autism, often I see parents saying they want to hear from us to say, is it only mild? And if you say it is severe, then they obviously lose hope. Or maybe they think about, oh, this is hyperactivity, this is ADHD. I know, parents will say, I know that this is ADHD. And you're thinking, okay, if you know this is it, then why are you here? So they will come with that. And then some parents will say, if only you can treat my child's speech. So that is all a stage of grief, and they're bargaining. They're saying, okay, if only you can just make my child sit, everything will be okay. If only you can make my child's eye contact better, everything will be okay. So there is a feeling of helplessness in parents. And how can a parents, without understanding the problem, help the child? So I'll tell you a brief story about 6 blind men who were asked to examine an elephant and tell how an elephant looked. And because they were blind, they looked at the elephant from where they can feel it. They can't see. So some said it's a fan, some said it's a wall, some said it's a rope, some said it's a snake. So that's how autism is, that anybody who sees what they are seeing, they define it in that way, and gradually things progress without looking at the whole elephant. So when a child is being evaluated after identification for autism, I don't know if I missed a slide, no. Then a doctor just have to look out for typical autism with typical features, or autism with cerebral palsy, or a syndromic autism, or an underlying encephalopathy. And that's what I do in my course. So I talk to families, I've made courses to say autism could be typical, or it could be associated with other conditions. And that should come in the evaluation part. And next, if I take my neighbor's key and try and open my house door, obviously the door is not going to open. So if the door is not going to open with my neighbor's key, what is the problem? Is door the problem? No. So if a child is not getting better with the keys that are not supposed to get the child better, it's not the child which is the problem. We're just not putting the right keys. And what is the right keys? That we'll try and know a bit later. So what are the barriers that I feel are there for early intervention? Most programs are parents-led, and child-led strategies lacking. So when I speak with any developmental pediatrician in India, a lot of them are my friends, and they say parents don't stay. They come, they stay for a few months, and then they go away. And the biggest problem is that parents come with an expected mindset. They want to normalize their children, and they don't want to look at the strength and difficulties and how to help the child based on their level. They are fixed in their mindset. So the first biggest barrier is to look at how we can overcome the parental expectation so that they can look at their child and understand what the child's need is. If they have unusual expectation for the child, then it is not going to do any good to the child, it will harm the child. So it's really important to have that first. And then it's really important to have a problem and strength based on the diagnosis. And all of that I have developed in my course, which has been piloted on doctors and psychologists. And we're doing the same pilot in the UK as well. And the aim is to know the whole elephant, because we're just not doing it right anywhere, including UK and Europe. So what is the meaning of child-led? And why is the child doing? So suppose a child is not even listening and not responding, and is just repeatedly playing with a toy, then how do you make it child-led? Or if you have visual cards and you show the child doesn't listen, and then they give up, say, no, this child is not even looking at the visual card. What can we do? So how can we make it child-led? So we can't make parent-led, because that's not going to be possible. The child is not going to listen, and new behaviors will come in. and then they'll go for new behavior therapies, and it's a cycle which go on and on and on until the parents run away in a private setup. In a government setup, that's not even an option in the UK. So one of the successful treatment or therapies that is recommended for autism is called applied behavior analysis. And I think it is poorly understood, and I think it is poorly applied. And people don't understand that it's really hard to look at the antecedents. Antecedents means what is the situation? So suppose the child has come to an airport and for the first time, and a behavior has come. So that's an antecedent behavior consequences. Consequences, child starts shouting. So an applied behavior analysis will look at the behavior, will go back and look at the antecedents and look at the consequences, and then provide behavior intervention or whatever. And this is said to be the gold standard for autism management. But I think there are hundreds of behavior in autism, and for hundreds of behavior, hundreds of situation, and some of the behaviors are regressive. So child was doing, not doing, child is gone back and is toileting, and some of the behaviors are really, really hard. Sometimes they're making noise, sometimes they're scratching, sometimes they're licking, or eating inedible things or not eating. There's so many behaviors. How do we do an applied behavior analysis manually? I think is very, very hard. So what is my approach on it? So I have seen what can change. So if we put a mango tree, and if we put in the right side soil, and if we put sun and right fertilizers, it will give out mango. We know that. So we can't change the genetics. It will not give lychee. It's not going to give plum or strawberries. It's going to give mangoes. So we can't change the genetics. With the nutrition, if we give more water, the plant is going to die. If we put more fertilizers, there'll be problems. So by giving more nutrition or giving more micronutrition is not going to do much good. Yes, you can replace as much as you can, but some things are not going to help the child. There has to be problem-oriented approach. So in the brain, when a baby is born, the pathways are developing. So suppose you're listening to me, your pathway is developed. So from your hearing center, it's going to your memory, going to your higher intellectual center, maybe the parietal lobe, and then going to your frontal lobe, and then it's acknowledging. So the pathway is developed in the brain. That pathway is not developed in babies. And the reason nature has done that is that nature wants variability, nature wants evolution of humans, and the humans involved based on their experience. So we can't change genetics. We can change a bit of nutrition, but if we don't change the environment of the child, we have the experience of mushroom. Long journey for parents. First, they want a diagnosis, then they're not sure, they're confused. Then they're looking at internet and Google and looking at different therapies and looking for the best therapies in the world to kind of normalize their children. But the best therapies in the world are parents themselves. And the presenting problem change over time. So people think that, okay, autism is a speech problem. If the child starts talking, everything will be okay. Incorrect. So the head of the mushroom will come. And when the head of the mushroom comes over the period of time, they're not prepared for it. And then everything falls into place. And it's very costly, as you see, it's very costly and less effective to treat the head of the mushroom. But how do we change it? Let's switch it. Let's start from what are the problems when they grow up. Let's start from there. So the parents are prepared, they know what challenge they have, they know what is the goal. So how do we do it? So first of all, we have to answer the parents' question in a scientific way, in a way that they can understand that what can change and what can't change. So their questions could be, why? Why me? There's no family history, why me? And how has this doctor decided? He's not even done a blood test. How has this doctor decided that my child has autism? And then they look at the day-to-day problem. They might not look at the long-term problems. So it's really important to know, to say that, look, what is happening day-to-day is building the child's brain, and that will make the long-term problem, because the child will have a choice in their brain pathway. And once they have a choice, it just keeps on developing it. And then slowly there will be more psychological and psychiatric problems that will come. And if you deal with it better in day-to-day life, you change that pathway. That neuroplasticity, as Dr. Alka said, is still possible at an early age. And that's why we have been able to achieve almost 60% result in our population. And the child-led way is the only way, because if you force them, these children will get more anxious, they will have more behavior, and autism is not really treated like that. So how do we help parents? I don't know if any one of you have jumped from a cliff, but it's a strange feeling in the tummy. If you jump from a very high height, and so there is a time before you land, and that's how parents feel. So once they know there's a problem, it's something unexpected, they have other busy things to do in their life, and suddenly this thing has hit them. And it's like having no feet on the ground. So, and you ask them, look, this is the problem, you make it child-led. And they will look and laugh at you, and they will say, what? How do I make it child-led? Child doesn't even listen to me. So this is where the parents are. And that is the biggest challenge of any early intervention, and to deliver a neurodisability part of it. So in a parent's journey, we needed a system which can identify denial. Denial could be, what is the child problem? They say, the doctor said it's autism. I don't know. So it could be denial, or could be anger, that, oh, my wife ate mangoes in pregnancy, so must be her. Or maybe she went to her in-laws. So anger could be there. And then depression, that, oh, it's all worthless, everything is finished, I can't enjoy my life and stuff like that. Or it could be bargaining, thinking, okay, if only if my child speak, that's it, everything is okay, I'll manage. And they come to a doctor and say, doctor, please let my child speak, and that's it. And if you don't, then they'll go to other, and then they'll go to other, and that continues until they realize that it's not going to happen. And the acceptance is where it all begins. And sometimes it can come early. The reason I'm doing this conference, the reason I'm talking to everyone and doing this on a Sunday morning here, is because if I can help one child and one family to understand that a grieving process will ultimately destroy the family, destroy the child. And if one family can change with this talk, that purpose of me doing this will be accepted. So it's important to understand what is the child saying. So there is more anxiety in autism. There's lots of evidence to it. So anxiety is a feeling when we all feel anxious. So suppose sometimes you have to give a presentation, you're thinking, oh, I'm anxious. That's normal. In autism, they will get anxious on very, very small things, which other children will not. And they will get anxious for a very long time. So they might get anxious, they might stop eating, they might stop drinking. So all of those autonomic behaviors comes in a very profound way in autism. And that is the biggest problem in autism. And often when we work on the ability, so ability talking and sitting, and the behavior goes worse. Then we work on behavior, the ability goes worse. And that's what is happening. Everybody is kind of doing ability, behavior, ability, behavior. So if a program focuses on improving the child's ability without observing how they feel, it will lead to new problems, and the new problems will lead to new problems, and it's a cycle that carries on. So a good early intervention program should address parental grief in starting, understand autism, all of that. We have made courses, which is available on Earlier Solution. Please do them. And these courses will let you really, really improve the communication that you have with the family, having a very honest approach that can be done. And what is normal? We have to know what is normal, because most children don't have brain damage. Most children don't have mouth problems or hearing problems. So we need to know what is normal for autism, why, how to deal with these behaviors so they get away. And the aim is to change the processing in the brain. And what are my plans? So all of that can be explained with our model of developmental and applied behavior analysis. Means if a child is doing a behavior, that depends on their developmental age, which means that somebody is like 4 years old doing a behavior, but their developmental age is 1 year of age, and they're doing that behavior, then we take that into consideration apart from just the antecedent. And a combination of developmental age, antecedent, and behavior would lead to consequences. And in our system, we have about 19 areas with about 56 like sub areas, which are automatically profiled by an algorithm. And if I do it manually, it takes me 2 hours, but the algorithm does it in 5 seconds. So because there are so many variables to count for. So how does it work practically? So this is how it looks to parents. So the parents will say, oh, my child is not talking. Yes, I've heard you. But the child is 41 months. But if you look at the developmental age, it's about 12 months. So the child is proportionately in 12 months. This is a live child we had. And this child is at 12 months. So parents say, okay, fine, I have to catch up by 2.5, 3 years. That's my goal. So instead of speaking, they will come to, okay, I have to catch up with my whole developmental profile. And then this is called understanding and listening and attention span. Now, if the child is not listening, the understanding will not come. The child is not understanding, the speech will not come. Speech has got various subcomponents, like what is the vocabulary, how is the comprehension, how is the clarity, and all of that is covered in the speech part. So when a child is assessed by our system, they just put in the data and this profile comes up, and this also looks at child's behavior. And usually a child with a chaotic home environment, with unusual parental expectation, unusual activities at home, this behavior is very high. And it's looking at how the child is listening or connecting or doing repetitive behavior and stuff. So all of this is explained to parents. They have a course, and the beauty of the program is the parents do the same course as the psychologist, as the doctor. So everybody has the same information. And it automatically generates 6 or 7 videos, which is the level that they have to do at that stage. And this is the free app the parents can download. So you just have an assessment somewhere, you get a report, you get a home program delivered on your phone. But this is not one hat for all program. This is a tailored program, which they get to say, this is your child's level, it's at 12 months, let's work on these things. And it looks at 19 areas. And it also looks at parental stress index, which is very important. We need to support the parents. I always say we're not treating children, we're treating parents, and sleep and diet. So this is the same child. Now this child is from 41 months to 46 months. And you can see with this intervention, the child's developmental age has come from 12 months to 24 months in 6 months' time. And we say, yes, the program is going well. The behavior profile has come right down. So from somewhere about 18 or something, it has come to 12. And we can actually see that things are improving and the program automatically changes, new program comes, new video comes, and the program grows as the child grows, and it's easily delivered, it doesn't need specialists to do it. So once they are trained, it can be done by a pediatrician and a psychologist. And we have done it for now 3 years to kind of say yes. And this is the last assessment. And now the child is 57 months. And you can see that most of the behavior has come right down. And this child has gone to mainstream school without any support. And this child, you can see that developmentally, the child has come from 12 months to about 36 months. So in about a year and a half, the child covered almost a year and a half to 2 years of gap. And that we call as result. We will call this child again in 3 months, 6 months, and 1 year, and later on yearly to see if any of those autism criteria are affecting the child, how is the quality of life, and if they have received early intervention, then what was the final outcome? And we learn from it. It's not a final setup. We have full system to learn from every child, from their feedback, and how we can reflect it back to the identification, evaluation, and even one child is important to us. So I call it IBAC, and the app I named on my son Dhruv. Algorithm-based delivery, outcome measured, and they go to and fro with each other. Thank you.
Thank you, Dr. Rahul, for this talk. And I think it is the best approach where parents are also incorporated in the treatment system. And many times I have seen that where there is a decrease in the parental stress index, there is definite improvement in the children as well. So we are going to ahead, and next talk is by Dr. Maramba from UK. Dr. Maramba holds a medical degree from the University of Philippines College of Medicine. He also has an MSc in Health Information Science from the University of Warwick. His work in EPIC, eHealth Productivity and Innovation in Cornwall and ISILS of Chile, is focused on user experience, usability, and evaluation of digital health applications. Welcome, Dr. Maramba, and his topic is basically based evidence, listening to parents, and moving towards best practice.
I'm sorry, I'm just
Dr. Maramba.
adding Dr. Maramba to it. So I'm just adding him. He'll be 1 minute. Sito, are you able to share your screen now?
Yes, thank you very much, Rahul. And thank you very much, Dr. Yadav, for that introduction. I hope you can all hear me. We just, oh, there you go.
Thank you, sir. Sir, your
Right.
screen is not visible.
Okay, so I'm going to share my screen now. So I hope you can all hear that, see that.
Yeah.
Yes,
Now it's
okay.
ready.
Thank you. So, yes, I was asked by Dr. Rahul to give a talk today about the work that we're doing in patient and public involvement with iSpectrum. Uh, as I was introduced by Dr. Yadav, I'm working as a research associate in the eHealth Productivity and Innovation in Cornwall and the Isles of Scilly project. And iSpectrum under Dr. Rahul is one of the companies that we're supporting. So basically listening to parents, patients, and the public, that in the UK that is known as patient-public involvement. So in the UK, that is the patient-public involvement is defined as research that is carried out with or by members of the public rather than to, about, or for them. So in this definition, this shows that the members of the public or patients are active participants in the research, right? You're not just collecting data about them, but they are actually doing some of the activities or even to the point of all of the activities that's normally carried out by what we would call research. So when we talk about public, this refers to patients, potential patients, carers, and the people who use health and care services, as well as from organizations that represent people who use these services. So in the UK, the national policy is increasingly encouraging public involvement in research. Now, they have identified 3 distinct ways where the patients and public can contribute to research. The first is involvement. So that goes back to what I said is the definition of patient-public involvement. So these are when they're actively involved in research projects and in research organizations. So this means that they take part, not just take, that they actively do some of the things that the researchers normally do. They can do data collection, they can advise or help in the design of the research, or they can also have a say in what the research is about. So what data fields are to be collected and so on and so forth. In participation, this is where the people take part. So this is where the people are the subject of the research. So they are the sources of the data. And in engagement, this is where the information and knowledge about the research is shared with the public. So if you want to get the public involved in research, here are some examples. I touched on this briefly just a while ago. So they could be as joint grant holders or co-applicants on the research public. They might get involved in identifying the research priorities. They could constitute a project advisory or steering group. They can comment on and actually give suggestions about patient information leaflets or other research materials. They might actually do the interviews with research participants. So, if it's just a question of getting the stories of the participants in the research, you could involve the public in that. You don't have to get a trained researcher. And they can actually carry out a research as a user or carer researchers. And the last one becomes especially important in things like mobile app development or eHealth app development. Now, when it comes to engagement, so we said engagement is dissemination of research findings or research knowledge. So this can take the example of, for example, if your institution holds a science festival that's open to the public with debates and discussions. It's promoting awareness of the research and research results through media such as television programs, newspapers, and social media. So, of course, the mainstream media like TV programs and newspapers, but now also social media like Twitter and Facebook become outlets for dissemination of research findings. And then you could hold your own fora through direct, or you could do direct dissemination research, which is through email or ordinary mail, surface mail postings of papers to colleagues, the research participants, and members of the public of the findings of the study. So these are all examples of how you could engage the public with the results of your research. So again, as I said, participation is when you recruit people to a clinical trial, or if you ask them to complete a questionnaire or participate in a focus group as part of the research study. Now, I mentioned before involving people in research and them actually being an active part of research. And one method for this, especially now in designing apps, but this could also apply to designing health programs or clinical programs. And this is called co-design. So this is when you involve the users, the people or patients, the stakeholders, which are the decision makers. So these are your health service executives, the managers of the health service, and the practitioners, the frontline staff. So these are the general practitioners, the nurses, and other healthcare staff. So involving all these three in the process of designing a digital product or clinical pathway or clinical program. So it's important that everyone affected can give input into the process. Usually, in the past, it's only the last two, the stakeholders, the decision makers, so your Department of Health executives and managers and the practitioners who would be involved in designing a digital product or clinical pathway. But now there's increasing involvement of the end users, or in this case, the patients, in the design process for a clinical pathway. So I'm going to talk about some of the requirements that we have in the United Kingdom in designing applications or digital health applications for health and social care. And one of these, which was come up with by the National Health Service, specifically the branch of the National Health Service called NHSX and NHS Digital. This is called the Digital Technology Assessment Criteria. And these are a set of criteria that was come up by an expert group that will give the staff, patients, and citizens confidence that the digital health tools that they use meet clinical safety, data protection, technical security, interoperability, usability, and accessibility standards. So what this is doing is taking all of these standards that are used in the digital world, in information technology. So we're talking about data protection, technical security, interoperability, usability, accessibility, and including it also clinical safety and efficacy standards, effectiveness and efficacy standards. So joining up the two together, because we know that digital health tools will have to be safe, they have to be effective, they have to be efficacious, just like any drug or health technology. And you have to marry that up, you have to combine that with the information technology standards around data protection, security, etc. Okay, for this to give confidence to patients and practitioners and healthcare practitioners that these are effective and these meet the necessary standards, so that it will have the best application, and this will also lead to more widespread adoption. So that's what the DTAC is for, both to ensure that these are of quality, and because we are assured that they are of quality, it leads to more widespread adoption. Okay. Now, as I said, there are several aspects to it. Since I am a research associate for user experience and usability in the context of the EPIC project, my focus is more on the usability and accessibility. So this is just one section of the digital technical, the DTAC, the criteria. And specifically, it states that for usability accessibility, the designer, the developer of the digital health application should be understanding users and their needs in the context. So there's a need to engage users in the development of the product, not just asking them afterwards, after the product is developed, is this okay? In the actual development stage, you need already to be consulting and understanding the users and their needs. And they need to show the work towards solving the whole problems for users. So this is done by doing what's called key user journey mappings. So it is understanding what the user will be doing throughout the whole journey of using that application. And this can only be done, again, by consulting the actual users, or you're consulting the actual potential user base. And to ensure that the service is simple to use, you then have to do user acceptance testing to validate the usability of the system. And that's one of the things that I do in the EPIC project, and that's one of the things that I've been advising Dr. Rahul about, is what kind of testing can we do with users so that we know that the system is usable. The DTAC is also works in conjunction with a standards framework that's created by another quasi-governmental organization in the United Kingdom. And this is NICE, which stands for the National Institute for Clinical Excellence in Health and Social Care. So according to this, the DTAC tells you what criteria you have to meet. The NICE Evidence Standards Framework gives you a set of guidelines of how you might meet the criteria. So this shows you the kind of evidence, or what kind of evidence you need to present so that you can meet the criteria. So, for example, in terms of acceptability with users, you need to show some evidence that potential users of the digital health technology have tested it and found it to be usable. And it will help to show that implementing the digital health technology may be successful. So this means that you should be doing formal usability testing, and that the result of the usability testing should be presented. So this can be reports from the user group or user group testing, and it shows that the users have been consulted. So in the context of iSpectrum, IBAC, Drew, what have we have done so far in terms of patient public involvement is that we have held focus groups with parents, and this is in the context of co-design. So we've asked about the current provision of support for children with neurodisability. We've asked them how they think a digital solution would help. And we've asked them, is the proposed solution something that they would use? So you can see that this is really like at the beginning stage. We're not presenting them with the product right away and they just tell them to use it, but we're getting their input of what they would like to see in the actual product. And what we found from them is from the research to the above questions, they said that they've experienced long waiting times for support. They agree that a digital solution would be helpful because most of them are being parents of young children. So they're at that age, they're in that age group where they use digital solutions in other parts of their lives. So they agree that a digital solution would be helpful. And they experience interest in using the proposed solution. So this is just an example of the quotes that we got from from our focus groups. So they assume that teachers know about conditions as autism, but the experience is that most likely they are not. So at the moment, it's an optional module in training. So for limited practitioners. So even though they have to deal with children with neurodisability or autism, they may not may have actual formal training in dealing with it, although the parents might assume that they do. They also think that the app will be great in the next decade of younger parents because smartphones are the norm. I think it is a similar situation in India, but in the United Kingdom, you have like 98% of adults own a smartphone or well own a mobile phone, and the majority of them are smartphones. So as they become the norm, then a digital solution, which is very handy and very available, will become the norm. So this is just to show based on what we want to do next for IBAC in the UK to research about the effectivity, efficaciousness, and usability. We aim to recruit about 100 plus participants in the real world trial. The participants will be given access to the app and training via e-learning. So we'll go through the stages of recruitment, getting their consent, implementing the intervention, which is the IBAC, to both parents and teachers. And then we'll do baseline data collection, which as in the graphs shown by Dr. Rahul earlier, we would get the measures I showed. We'd get their stress index, the frequency of problematic behaviors. We may collect things like quality of life data, etc. But aside from this quantitative data, we will continue to do focus groups with the teachers, and we'll do that at 6 months and 12 months. By the way, these focus groups, because of COVID, we had to do it using the platform that we are using right now. We had to do it remotely by Zoom, but we were able to get comparable results to what you would normally get in face-to-face focus groups. So we'll also constitute an advisory group based on the parents, and we also are getting input from teachers and professionals in the advisory group. Okay, so that's my talk about patient public involvement. If you want to learn a little more about the EPIC project in the UK, and this might also serve as, I don't know if you have similar projects in India, but this might serve as a springboard to implementing similar projects in India, where the academe works together with small to medium enterprises to develop the growth. But I know there's a gigantic apps development development ecosystem in India. As a matter of fact, some of our SMEs here in the UK, and specifically in Cornwall, where I'm working, outsource their program development to India. So we actually might learn from you rather than the other way around. So thank you very much.
Thank you, sir. Thank you so much for your nice presentation. And we all agree with you that there must be a digital solution from this neurodisability problem. As you have listened, that UP is the most populous state of the country of India, and 1 out of 11 children are suffering from some sort of neurodisability problem. And it is not practical and possible near future also that we should develop more neuropediatrician, neurodevelopmental pediatrician, and they will deal. It is better to develop these digital solutions to solve this problem. Thank you so much, sir. And our next session is research paper presentation, and chairperson for this session is Dr. Rasmi Kumar ma'am. Ma'am is the ex-professor and head department of pediatrics, King George Medical University, Lucknow. She is graduated and postgraduated from AIIMS, New Delhi. She worked in United Kingdom between 1981 to 84. She has been a medical teacher at King George Medical University, Lucknow for 35 years. Ma'am put her whole heart and soul for developing a specialty pediatric neurology in the state of Uttar Pradesh till her retirement in July 2019. She ran a busy pediatric neurology clinic every week. Her special interests are infectious disorder of the brain, epilepsy, and cerebral palsy. She was president of the Association of Child Neurology from 2015 to 16. She has conducted over 13 major research projects as principal investigator on neurological problem in children. She has also won 2 national awards from the Indian Council of Medical Research. Her research and clinical work is recognized by scientific bodies like National Academy of Science India and National Academy of Medical Sciences. Welcome, ma'am. And before starting to this session, I would like to hear from you about your experience of ACVR as well as Brainrakshak project. Over to you, ma'am.
Thank you very much, Dr. Yadav. I'm very pleased to be here and contribute in some way to this teaching program. I'm really, I must confess that as I was in college, we used to look. My video has been shut off actually, so I'm not visible to anyone. Anyway, so I was, we used to look around for so much of it. Suddenly, once I'm in the private sector, I'm doing my own clinic. Autism.
Next, sir, please mute yourself.
So I think it's a huge problem. It's either it's growing or I'm seeing a different kind of patients in the private sector. I can't say, but we are seeing a lot of it. About Brainrakshak, I have heard about it from Rahul. It seems very, very promising, very, very sort of, we are full of hope because, what is the answer to so much autism? You have to have therapies for it. And, we tell the parents, look, there are no drugs for autism. You have to have one-to-one teaching, one-to-one training. And, you can see that it's for each patient, for each family, it's so difficult for them to come to your clinic or come to a school every day. How do they manage? I mean, the whole life changes. So it's such a big challenge to manage autism in India, and especially in smaller cities in India, in Uttar Pradesh, and in all the varied settings of our society. So it's just, it's a huge challenge for us how we manage this. And maybe Brainrakshak, which is actually targeted to parents of children with autism. Now, we think that it could be a game changer. So we have full hope, because, how do you tackle it otherwise? The parents cannot come to you every day. There are other responsibilities that they have also. They have other children. All the time on hand cannot be given to just one child. So this is a very, very huge problem. And I hope the Brainrakshak program will, make a dent in solving this problem. So now, having said that, I'm coming back to what we have on hand, and that is 2 paper presentations. I'll just read out. The first one is Dr. Kehkasha. She's an assistant professor, PhD in clinical psychology, and she's presently at the Department of Psychology, Tikaram Girls Degree College, Dr. B.R. Ambedkar University, Agra. So she's joining us from Agra, and she's talking about caregiving burden and anxiety in family caregivers of the patients diagnosed with intellectual disabilities. So Dr. Kehkasha, please.
Good afternoon, everybody. Myself is Dr. Kehkasha, as you know. Let me start. Whenever I was working in OPD, I thought that everybody in health sector or in society, everybody is talking about and they care about the children who is suffering from intellectual disability. But there is a lack of the researchers, or there is a lack of researchers who targets caregivers of these patients. So I selected this topic in which I aim to examine the caregiving burden and anxiety among the caregivers of ID patients. And for this, I tried to find out the association among severity of intellectual disability, caregiving burden, and anxiety. For this purpose, I took 190 consecutive primary caregivers from OPD.
Dr. Kehkasha, do you have a presentation to share?
Please unmute yourself and if possible, share your slides.
Okay, sir. Now, is it visible?
Yes, it's visible.
Okay.
Please
Okay.
make it
Then, okay.
Please make it full screen.
Yes. Give me a second. Actually, this is PDF file. I'm thinking it's PDF file, so I couldn't make it fully visible.
Okay, it's visible.
Are you okay with it?
Yeah.
Okay.
You go ahead.
Okay. For this study, I took 190 consecutive primary caregivers from psychiatry OPD, and data was collected from January 2018 to December 2018. And the inclusion criteria on which I took the primary caregivers was those patients who were intellectually disabled, diagnosed by DSM-5, and who only those caregivers who have biological relationship with the patients, and who were not receiving any psychotherapeutic treatment for any reason. Those primary caregivers who were not primary caregivers for the patients were excluded and who were not receiving any psychotherapeutic treatment and who were suffering from any kind of medical illness, and those caregivers who were not whose patients were enrolled in any special school were excluded from this study. So there are following tools that I used in this study were semi-structured socio-demographic and clinical data sheet, violent social maturity scale, Stanford Binet intelligence scale, Hindi version, Zarit burden interview, and Hamilton anxiety rating scale. Here are some results of my study. Primarily, I saw in this study that most of the patients in this study were male, Hindu by religion. They were suffering from mild level of intellectual disability, and in 12.11% patients, they were having comorbidity. Most of the patients were adolescents, and the percentage of these type of patients were 45.3%. And if I talk about the characteristics of caregivers, you can see here that most of the caregivers were female, Hindu by religion, living in rural area, belonged to lower socioeconomic status, and they were living in nuclear family. They were illiterate, and primarily they were mother of the patients. So there is the results, and I can see here, and all of you can see here that most of the primary caregivers were suffering from mild to moderate level of caregiver burden. That was 41.6% of the caregivers, and 42.6% primary caregivers were suffering from mild to moderate level of anxiety. When I find out the correlation among all these variables, I found that intellectual quotient and anxiety have negative correlation, and this correlation is significant. And same here, IQ and caregiver burden was negatively associated and significantly associated with each other. The most interesting fact I found here is that anxiety and caregiver's age was significantly and positively correlated. Same here with the caregiver burden. Caregiver burden, anxiety, and caregiver burden in their age was positively and significantly associated. So when I tried out to find out the significant difference among the different level of intellectually disabled caregivers, so you can see here that difference was found among all the caregivers who had different level of intellectually mild disabled patients on caregiver burden. It was significant, but on anxiety there was there was also significant difference. So from this study, I can conclude that caregivers of intellectually disabled patients are suffering from several objective and subjective problems, and they are vulnerable to any kind of psychiatric problems like anxiety, depression. So there is a need to focus on them too, to provide them better health care, better mental health care. So here I'm done. Thank you so much.
Thank you, Dr. Kekasha. That's an interesting paper.
Thank you, ma'am.
Yes, and I think it's an important topic also because we always talk about the patient, but we need to focus a lot more on the caregivers. And
definitely.
So you've looked at the caregivers, and what were the determinants of their anxiety and the caregiver's burden? So, and what were these things? So one of the things that the age of the caregiver.
Yes, ma'am. Yes, ma'am.
And so you found that the younger the age, the more
the
more the burden. Is that
yes,
it?
No, ma'am. The older the people, older the age of the caregivers, they are probable to having anxiety more than those people who are young in their age. Anxiety and caregiver burden is higher on them who are older.
Has less, less severe in disability than the level of anxiety.
Yes, ma'am. Yes, ma'am.
That is understandable. Does education Shouldn't make any difference. Education.
No, ma'am, there is no significant difference in educational level of these caregivers
No, I mean,
on anxiety and caregiver burden.
yeah. Was that affected by education of their own education?
Ma'am, it might be possible that most of the caregivers were illiterate, so so I couldn't find any significant association between these two factors. So in future, I will try to find out that.
Okay, thank you, Dr. Kekasha. And now we
Thank
move
you so much, ma'am. Thank you.
on now. The next presenter, who's Ms. Sadaf Merchant. She is a clinical psychologist and chief learning officer in Energia Wellbeing Private Limited. So what kind of organization this is, I'm not very clear about. But anyway, you're talking about significance of personalized cognitive intervention strategies to improve learning outcomes in neurodiverse learners. So interesting topic, and I hope you're going to explain it all, Dr. Sadaf. Over to you.
Thank you. Thank you so much, everybody. And I got a lot of insight today from all the doctors who I heard them today. Yes, I do come from the school of thought where I personally also believe that the early we start the interventions with the children, the better the development and the better the coping. Because when you talk about students especially, okay, by the time we start intervention with them, it's almost 12 and 13. So from 0 to 10 years, there has been no adaptability, no focus, none of these factors have been there. So I have basically used, so Energia Wellbeing is an organization which works on the principles of positive and preventive psychology, and where we use different cognitive strategies using multisensory approaches with the children to help them overcome their learning problems, their learning outcomes. So when I talk about this overall study, okay, I start with the fact that when you talk about neurodiversity, you're basically talking about how each one of them thinks differently. And our organization and me as a clinical psychologist, I personally focus on empowering these different thinkers, because if you actually work with them, whether you talk on a spectrum, inattentive type, hyper type, mild to moderate autism spectrum children, or you're talking about the overall learning challenges, all these children have a different approach towards the way they learn. Okay, probably I would have a way where I would prefer to write down and learn, whereas some children would have a way that can somebody explain it in their own words and then they would read, or somebody would find things difficulty to just coordinate. So often the sight word problems which we see in dyslexia children, they say it is just because they cannot recognize, but they don't see that when I'm looking at something, I look at CLOUD, cloud. But when I'm trying to write it, somewhere there is a transposition in my brain, and due to which I write the word as could. So there is discrimination problem, there is coordination problem, and the readiness of the immediate memory to put it down in the same way. So what we see is every child learns in their own way, and we need to support their learning. We need to support their intervention, giving them more, something which is more personalized to them. We often come across parents, if you pick up surveys, if you pick up researchers, we come across parents who feel, oh, this child got A grade, let's adapt to his strategy. Your child is an inattentive child. Your child is a slow learner. Your child cannot follow things that way. So you're enforcing a kind of a learning pattern and a behavior where your child will not be able to adapt, and then you come back with that frustration, irritability that we try our best, but our child is not able to succeed. So we think that if we pick up Piaget's cognitive developmental milestones, and if we start taking those early interventions, we will be able to work with empowering these children to cope up with their regular school curriculum. So my research focuses on structure of intellect concept. Now, structure of intellect concept, as we all know, is given to us by Dr. J.P. Guilford, which was further researched by Dr. Mary Meeker and others in the University of Southern California. And this study was actually supported by the US Defense Department. The overall concept says that the human brain has 90 thinking abilities. And each of these abilities are, helping the child to create a new neural pathway. Now, when I talk about 90 abilities, it's about a simple example which I would like to give. When I show a child something like this, probably his visual recognition would be, this is a glass of water. But the moment I may write it as a sentence, he may not be able to read, he may not be able to decode, and he may not be able to focus. So our brains have muscles. And if we do proper cognitive perceptual exercises, we can strengthen a specific area in a child. Of course, if the child has neurodevelopmental problems, the problems will stay with the child, as even the doctors have said over here. But we can actually help the child to, be a little better at it and cope up with it so that they can, do their day-to-day tasks. So all we want these children, from severe to mild to moderate, on whichever level they fall in, to support them with the learning cognitive, skill sets, which can help these children to become more and more independent as they grow. Because when you keep growing and you know how to cope, you somehow know how to deal with it. So even when I talk about an ADHD child, a hyperactive child, if you actually see, they have good spontaneity. Now, how do we navigate their spontaneity? By using these cognitive strategies. So with structure of intellect, what we did was, they have assessment tools. It's an evaluative tool to know how are you on your auditory memory, to know how are you on your visual memory skills, to know about your sequencing, to know about your visual closure, visual discrimination. So there are different learning abilities. What we have done is, we did a qualitative analysis, and we had two groups of students, basically students who fall, between the age group of 4 to 8 years, underwent the PLA assessment, which was for smaller children, and children who were above the age group of 8 underwent the ALA assessment. Now, when we did this assessment gives us a result, okay? And that result gives us a cognitive program, which is for the next 80 hours. This 80 hours of program needs to be spread over a duration of 4 to 6 months or 8 months, depends upon how the child is, adapting, learning, and coping with that course. The course is executed in the form of play cognitive activities. It has specific instructional worksheets for the children, and we incorporate certain activities using the medium of, computer module exercises to stimulate their visual skills and their auditory processing skills together. And the fourth part of this program is,
excuse me, Shadaf, you have only 2 minutes left, please.
I will be done, sir. Yeah. So in this program, we also see, we use a lot of physical exercises, like, you can say sensory integration exercises. The method was done in a way where we did a pre-evaluation 80 hours program and a post-evaluation. And we found that the study was significant, where when we did the mean analysis, we saw for primary learning ability, it was an improvement where we got the p-value by 5.9. And for advanced learning ability, which was for the children who are the age group of the above, that is 8 years and above, were on 3.48. Their pre-scores were, for advanced learning ability, 3.11. And after post-assessment, which is after 80 hours of program, it was 3.48. So we saw a significant improvement. The conclusion of my study is very, very simple, that if we give cognitive specific instructions to the children who fall under the whole neurodiversity of umbrella of terms, every child will have their own way. Even if I pick up 2 children who have probably ADHD or dyslexia, and who both of their age could be 7 or 8 years old, not necessarily their requirements would be the same. I have a fleeting attention with auditory instruction, and the other child could have a fleeting attention with visual instruction. So no two children under the same cluster, under the same age group will have the same requirement. We need to personalize our approach. We need to somewhere support their learning and help them become more independent with their cognition, which adds more like a life skill also for these children, along with their alternative therapies, which are also important. That brings an end to my research. Thank you so much.
Thank you so much, Sadaf. That was a good presentation, and we totally understand the, the reasoning behind it, the logic behind it, that if you have actually tried to analyze the strengths and weaknesses, you can say, of individual children, and then tailor your program, your cognitive, your teaching program according to that, then the improvement is much more rapid. That's what you're trying to say. Okay,
Yes.
they make up for their skills much better. Now, the only thing is that, ultimately they should go into regular school, isn't it? They should go into class.
Right. Absolutely, absolutely, and that's what we also aim for, ma'am.
Okay.
Thank you, Sadaf. Thank you, Rasmi ma'am, for joining us. And our next session is role of digital technology in neurodisability, and speaker is Dr. Venkat Reddy sir. Dr. Venkat Reddy sir is a consultant neurodevelopmental pediatrician and lead clinician, community pediatric service. He is officer for digital health for the Royal College of Pediatrics and Child Health, UK. He is also data security officer for iSpectrum. Welcome, sir, and over to you.
Good afternoon, everyone. Can you see my slides and can you hear me okay?
Sure, sir. It's visible and you are audible.
Fantastic. Thank you very much. I'm glad to be with you all. I started my pediatric journey in India. I graduated from SV Medical College in Tirupati and moved to UK about 30 years ago. And then all of my actually pediatric training, neurodevelopmental training in the UK. So just declaring some of my conflicts of interest, in addition to helping Rahul with iSpectrum, I work with a number of private research universities, academic health centers, and the Royal College of Pediatrics. So I'm talking today in my personal capacity. So I'm not representing my employing organization or the Royal College, but these are my conflicts of interest. So I work with a IT consultancy in Cambridge called Future Perfect Healthcare. And we work with digital interoperability, electronic health records, artificial intelligence. I'm a medical director and AI lead. I'm working with an Israeli startup called Illyria, where we're trying to diagnose ADHD by measuring activity levels through smartwatches. And more importantly, for what we're talking about today, I'm also working with a physiotherapist who works in the NHS, but originally from Chennai, called Sharon. And we're developing a personal health platform for children and young people with the disabilities, where the parents can control all the information and integrate with something like iSpectrum and able to pull through all the information, control everything they want, keep a diary of things, learn about the videos, and interact with all the education, health, and social care professionals. I've been very lucky within my training. I'm a member of a NHS Digital Academy Digital Health Leadership Program that's developed by NHS UK to develop health digital leaders. I completed my PG diploma in digital health leadership at Imperial and Harvard. I'm moving on to do MSc in digital health leadership at Imperial College London. And my dissertation is the use of machine learning for early diagnosis of autism. I'll speak very briefly about that. I also advise Eastern Academic Health Sciences Network about digital tools for the diagnosis of ADHD. And as you already mentioned, I'm Officer for Digital Health and Technology for the Royal College of Pediatrics and Child Health. helping the college to develop digital tools that can help with everything we do. That is for the children, for the pediatricians, and for the wider stakeholders we engage with. So for example, during the COVID-19, we have to conduct all our annual conference, training programs, and examinations by digital and virtual methods. And we will be continuing to develop those platforms and tools. So this is our Child Development Center in Cambridgeshire. This is where I work, and this is where I'm the lead clinician. We're very lucky that we actually designed and developed and built our own Child Development Center. So I'm one of the 6 neurodevelopmental pediatricians. We have a large group of physiotherapists, speech and language therapists, occupational therapists, clinical psychologists, child psychiatrists. Even during the COVID-19, we had to make a lot of changes as we removed a lot of toys and play equipment. We have introduced things like virtual reality, more play, which doesn't involve too much of touching, and changing our roof tiles so that we can project more of natural light in the sky. So making it as friendly as possible for the children, taking into account there is a less physical stuff available during the COVID-19. This is an example of profound change we can make using digital tools, even for the physical environment in which we assess, manage, and support children. So I'm going to be focusing on mainly autism and a little bit of ADHD today because I got only 15 minutes. So this is our fantastic Alka, who is our speech and language therapy lead. And this is our Child Development Center. We got a fantastic purpose-built room with a lot of toys and equipment, one-way mirrors, recording equipment. And before the COVID-19, a child with a potential autism would be identified by our health visitors who screen them at 6 weeks and 12 months and 2.5 years. They will be referred, seen by a pediatrician for a general developmental assessment. Then they will be seen by a speech therapist, psychologist, and occupational therapist for a diagnosis of autism and any other associated condition, like, for example, intellectual disability. And they will get a feedback from the consultant like me, and they will get a coordinated package of care, which is delivered by our multidisciplinary team consisting of our child and family support workers, pediatric psychologist, speech therapist, and occupational therapist. As you can imagine, we couldn't continue with that when COVID-19 hit us about 2 years ago, and I had to very rapidly digitize almost everything we do. So now we take the initial developmental history, talking to the parents by telephone, because that's the easiest thing to do. And we conducted autism assessments through live video conferencing using our own bespoke Attend Anywhere video consulting platforms. We also used parents to record and upload video clips from home of them playing, interacting, and communicating so that we can go as a professionals, code those things and make diagnosis by combining all this information. Some of you might be aware of a tool we all use to make a diagnosis of autism. That's Autism Diagnostic Observation Schedule, ADOS. But we could not do that during the COVID-19 as we couldn't bring the children into the clinic and interact with them at very close proximity. And that has been turned into an instrument called a BOSA that could be a brief observation of symptoms of autism. And that can be implemented virtually using a similar toys. Either parents can do it or live in front of a video at home, and we can score and make a diagnosis of autism. There are some fantastic but very expensive bespoke platforms for autism and ADHD diagnosis, some from USA, where parents will log on, provide all the history, upload the video clips of the child interacting, playing, and communicating, and the professionals would log into the portal and look at those videos, tick the boxes for the diagnosis, generate a report of the diagnosis automatically, and share that with the child and the parent and the professionals involved. But they're all very expensive for use in low and middle income countries like India. In UK, there are some private companies who do only autism and ADHD assessments completely virtually, and they don't do any in-person assessments. Helios is one of the companies I worked with, and they're beginning to become more and more common even in high-income countries at the moment. So our intervention program used to be about nearly 13 to 14-week program, starting with introduction to autism, and is delivered by speech therapist, occupational therapist, and psychologist. We used to do that in our child development center, some in groups and some one-to-one, and we digitized everything. And a lot of it is recorded and sent to parents as webinars. Some of them are delivered live with a small group or one-to-one. It just shows that almost anything we were doing in person could be digitized very rapidly using a simple tools like a mobile phone, Teams or Zoom, and the recording of educational videos Rahul is doing with a lot of other conditions. The ADHD as an example of digital tool, some of you might have heard of something called a QB test, that is a quantitative behavior test. Rather than diagnosing children ADHD just based on the questionnaires from the parents and the teachers, we can actually sit a child in front of a computer with a movement sensor and a video camera. They do almost like a computer game for 20 minutes. At the end of it, we can generate an objective measure of the attention, activity levels, and impulsivity, like a centile chart for the age and the sex. We've been using it in my service for the last 5 years for every child for a diagnosis of ADHD. That makes a big difference. And I'm advising our Eastern Academic Health Sciences Network to roll it out across the UK at the moment. So if you want to read a little bit more of all the stuff I talked about, I published a paper along with our fantastic team manager, Lucy Brumpton. This is the reference here in the Journal of Pediatrics and the Child Health. And talking a little bit more specifically about autism, I am part of the research group funded to the tune of £1 million by NHS England. We are looking at, for autism service within the UK, what diagnostic pathways work best for whom in what context. So we've done a complete literature review. We've done a survey of all the services. We're interviewing parents and the children and the professionals, conducting case notes reviews. So we'll be coming out with a guidance about what works. And these kind of things cannot be just lifted and shifted to India, but we can build on it, we can modify them, and we can make them context specific that suits the Indian children, Indian families, and Indian resources. So the last slide before I finish, how is the Royal College of Pediatrics and the Child Health helping with that? So there are a number of programs I'm leading and part of it. For example, we have a parent-held child health record called a Red Book, which used to be paper-based, where all the information about the child's health and the development and immunization and health visits are all documented, growth charts are completed. We are digitizing that at the moment, and that will be available. And also that will be extended beyond the preschool up to the 25 for children with the disabilities. You all know the paper growth charts. We are digitizing them, turning into an API, application program interface, that can be connected to any electronic health record. We're developing resources for helping children to take medications, and also using a lot of artificial intelligence and machine learning approaches to recognize children with any problem, be it autism or ADHD or cerebral palsy, or children presenting with acutely unwell, so that you get a clinical patient support system available to the clinicians and the parents. So that's what I just want to finish with today. So in summary, we are never going to be able to train enough specialists even in the high-income countries. With the advancement of digital technology, digital tools, mobile phones, data science, especially India is a world leader on that. We can do a lot of that using those tools. And our ultimate aim is to make the parents the primary caregivers. They become the primary therapist for the child. They document and they monitor their own development of the child using a simple app-based platform. And then according to the needs, they can seek what help they want. And our job is to make parents experts at supporting their own children. Thank you.
Thank you, sir. Thank you so much. And as we all aware that there is acute shortage of neurodevelopmental pediatrician in UP as well as in India. And it is not possible in near future also to produce such large number of required neurodevelopmental pediatrician as well. So
Yes.
digital platform is the need of our, and we must develop it and must be economical also for a country like India. Thank you so much, sir. Thank you so much. And next talk is from the Dr. Ujaina. Dr. Ujaina is talking about moving towards best practice and how you can be a part of it. A brief introduction of Dr. Ujaina. She is a training lead, eye spectrum chartered psychologist. Dr. Ujaina is a researcher and mental health professional working in the field of psychology. She is currently head of research at eye spectrum and the Association of Child Brain Research. She holds a doctorate in psychology, a master's in counseling psychology. Welcome, Dr. Ujaina, and over to you.
Thank you so much, Dr. Yadav. And hello, everyone. Thanks for joining us today. I'm Dr. Ujaina, Head of Research and co-founder, Association of Child Brain Research. Is my screen visible?
Yeah, it's visible. And you are audible.
So, Association of Child Brain Research for the last 4 years has been a leading voice for promoting evidence-based and ethical practice in the field of pediatric neurodisability, especially in Uttar Pradesh in India. And as the prevalence of neurodisability is increasing rapidly, so is the need to address and support this population, and especially their parents and carers. And if we talk about the current prevalence, I will not go into the statistics because it has been already covered by our previous speakers. There are around 2 million children only in UP with one or the neurodisability, at least 1 in 11 children. And these are definitely huge number. So to analyze the problem, we did a survey back in 2018 to see current outcome and practices in India. And we approached few organizations, out of which 20 organizations agreed to participate, who were working in the field of neurodisability. And we were interested in knowing who is leading the center and what tools or screening tools are being used to diagnose a child. Are there parents training program? Are the centers or the early intervention center, are they empowering parents or not? And what kind of treatment or therapy models they have been using? And what are the current results in terms of outcome and the interventions they have been using? So in the next slide, I will be covering about these questions, the findings on these questions. So to our first question, who is heading the center? Out of those 20 organizations, only 7 organizations agreed to present their work in the conference in 2019. And as we can see from this data that only one organization was working with MDTs and was headed by a pediatric neurologist. Rest of the organizations were either headed only by a psychologist, Ayurvedic pediatricians, or a ABA therapist, or a rehabilitation psychologist, or just a child psychologist. So we found that there is a gap in or lack of MDTs working together. Then to the second question on the method of diagnosis, we found that only 42.9% of these organizations are using standardized tools like ADOS or ADIR, and rest 57.1% of the organization were just using screening tool to start the intervention. And then on the parent training, the results were really positive on this aspect, as 71.4% of the organizations which we interviewed, which we surveyed, had some kind of parent training program, and they were including parents in the treatment or therapy they were doing with the kid. So moving to the next, out of those 7 organizations, there were only 2 organizations who were analyzing their results, who were analyzing if with their intervention, is there even any improvement, or is it helping or improving the outcome of the child? And the first organization reported that they had 76% of result, and the technique or intervention therapy model which they were using was based on ABA. And the second organization, which reported 85% of result, they were using in early intervention in a MDT environment based on developmental and applied behavior analysis. Rest of the organizations didn't reported any result because they were not collecting any data, they were not self-auditing their work. So to the last question of the survey, which was what kind of therapy or intervention models they were using. And we were surprised and quite alarmed with the findings, because few organizations reported the use of therapy which are not recommended by any international guideline, like hyperbaric oxygen therapy, chelation therapy, and stem cell therapy. And the rest of the organizations were using either occupational therapy as a standalone intervention, ABA or sensory intervention, communication intervention, and Ayurvedic intervention, or which they called as gut therapy. So as we all know that the first principle of medical field is that do no harm. And when we analyze this survey, and we saw that there are organizations which are using chelation therapy and hyperbaric oxygen therapy, even in 2018. So these are the guidelines from NICE, National Institute of Healthcare and Excellence, which do not recommend the use of chelation or hyperbaric oxygen therapy in treating children in any context. And the data I just presented is from 2018. So there is definite lack of evidence-based practice, which we are trying to address through ACBR. So what is the summary of the problem? The summary is that if we summarize it in 3 points, so we can say that there is high rate of disability and the prevalence is increasing, which puts a lot of need for services for this population. And then there is definite lack of trained professionals. And in the census data in 2011, the 40% of the population of children with neurodisability was from small cities or rural areas, which makes it really difficult to address, because most of the organizations are either working in metro cities, and there is a lack of such services in small cities. Then the third problem is that the system is really disjointed. And there are organizations, there are support system or monitoring there by the government, but they're not integrated. The organizations are working independently in a very disjointed way. And how is this impacting parents and children? So basically, the variability and certainty about outcomes and standard practices lead many families to enroll their children in several interventions simultaneously, because parents have very little or no guidance on critical questions like if I enroll my child in X intervention, or how will I predict the outcome of the child? Will he improve or do better in X intervention or in Y? And secondly, what if my child does program X, or if he's doing both the interventions, will this result in a positive effect or a detrimental effect? So because there is a lack of data on these questions, so parents are left on their own to decide which program to choose and which program not to choose, or which is best for their child. And in all these confusion, the only person who is getting impacted in the long run is the child, because he is losing the early years during all these trial and errors, sadly. So what is the solution to all these things? The only solution is to empower parents through psychoeducation and sharing the best practices in an easy to understand manner. And it's very important to involve parents and families in planning and delivery of the early intervention. So what is Association of Child Brain Research doing to achieve all this? So after the survey we did in 2018, the first step we took was to register an independent ethics committee with DHR, Department of Health Research, and CDSU, because it's very important to safeguard the patient's right and increase ethical practice. And this ethics committee registered with DHR and CDSU is headed by Dr. Rashmi Kumar now. And then we also have developed training courses so that the concerns of the parents can be answered and they can be educated about what is the science behind the diagnosis, what is the reason that their child has XYZ neurodisability, and what is the prognosis of their child. So these training programs are headed by Dr. Rahul Bharat, who is the founder for Genus Lane Brainrakshak project and iSpectrum UK. And the pediatricians are also part of it, along with the psychologist and the patients group. So then the third thing which we are doing is research. To measure the effectiveness of the programs, we are auditing the work we are doing, and we also have procedures and the programs in which the other organizations can enroll with us, and we can do an independent audit of their work. So if you want to know more about what projects we have and how you can be a part of it, you can visit our website. So in short, if you really feel that you want to be a part of this mission, then how you can do that is you can write us about the problems, the question which you face. You can even connect with us to solve them together, and we can educate and empower the parents and the professionals together. Thank you so much. And you can visit our website and write to us on research.acbr@gmail.com. Thank you, Dr. Yadav.
Thank you, Dr. Ujana, for such a lucid talk. And before winding up this session, I would like to invite Dr. Sanjay Niranjan sir for his concluding remarks. Dr. Sanjay sir.
Thank you, Dr. P.R. Yadav. Before I conclude, I would request Dr. Rahul or Dr. Ujana to answer two questions in the chat box. Dr. Reddy wanted to know a demo. How can he have a demo of the interventions? And Dr. Hima, she was requesting how to access these sites, whether they are child health services sites, whether they are in UK based or they are available somewhere. Dr. Rahul or Dr. Ujana, anyone can address these questions.
Okay, just a second.
You see the chat box, and in the meantime, I also I will I'm doing my job. I think as you see that the various data, they are saying 1 in 11 children, and my textbook says 20% of the population. So the textbook which I am quoting is from American Academy of Pediatrics, the research paper published in Journal Pediatrics of 2006. And that says, including mild and all behavior problems, that issue is 20% of the children. And more severe or more aware diagnosed problem, they may be 1 in 11 or so. So, to pick up the mild problems, where the parents go? So parents first go to the pediatrician thinking that pediatrician knows everything about everything of the child. So we are supposed to monitor and develop and at least detect these things and then guide them through the things which are explained in today's conference. So because cardiology is not may not be interested in this.
I'm not sure what happened, but I can't see Dr. Niranjan. But thank you very much, and everyone, for joining this. And we have a massive task ahead. And as Dr. Rashmi Kumar said, we are all hoping that we can help all the children and families. And they have lots of questions, and every family has got their own dynamics, and they have lots of questions. So what are the basics of early intervention? So I've tried to compile it all, and it is on the platform that you have registered. There are courses on autism early intervention for parents, for schools, for pediatricians. We are improving, and we are kind of putting in new courses, new information. We want to learn from your own experience. So I would say that please do the courses, give us feedback, and we try and do everything to the highest standards. So we've got platform all set up, policy set up, data policy and everything. So yeah, your feedback and support is very important. And most important things are activities and then research to make sure that we're doing the right activities in the right way so that it's helping us all to help children. So that is the aim. So Association of Child Brain Research, the purpose is to provide research which is useful, research which reduces cost, and research which can solve a problem for us all. So some of the questions that are in the chat box, I like the comment from Dr. Venkat that we need courses in all different language. Absolutely. I can only speak a few, and Dr. Venkat can speak a few, and we can combine together to take this best practice, at least in the whole of India. And then there's thing about if there are more caregivers. So grandparents are a blessing. If a child has grandparents, I think this is the most important blessing that they can have. But often they are on different page. So all they need to do is just do the course. And the course is simple enough for parents, for grandparents, and everyone to understand. So if you are all working together on the same page, I find so many mothers who feel isolated, alone, not supported by father. And that has a poor outcome on the child. Or I see so many families where in India, especially in North India, where grandparents are not understanding, not listening. So that is where we need to make the difference by using the power of knowledge, power of technology, something that they can watch on their phone, and maybe using more services like translation and stuff to help in different languages. Absolutely. And family intervention is what it is, because why it was not a problem 50 years back, and why it has become suddenly so much of a problem. So we become more isolated, we have become more digital, and children are exposed to more digital things, and population is increasing, so the percentage is also increasing. So I feel we need to go back to the basic interaction with the child builds their brain. That's it. How we interact with them is going to build their brain. That's what I feel. So there is still a lot of positive opportunities to change things and to get over the corrupt practices, which is growing. And I don't talk about it, but we can get over with knowledge and science. So thank you all for joining today. And
Thank you, Dr. Rahul. I was just concluding. I lost the connection in between. That the bar diagram which we have in our vaccination chart is the never developmental scale test, DDST. So for the motor follow-up, we are tuned up since our undergraduate days. So now is the time when we have this type of say monitoring for all the three streams and all its say sub components. That would be one. And the other thing you said, that the therapies like first do no harm. Many people are coming to us after getting their stem cell thing done or hyperbaric oxygen. So another thing is building confidence between the centers run by the therapist. They say now the child has been diagnosed with autism, ab doctor ka koi kaam nahi hai. This is our job. So we need to develop a confidence, as you said, a teamwork among therapist, pediatrician, and parents and school. That they have a combined responsibility where the pediatrician is the lead. Thank you, Dr. Rahul. Thank you so much.
Thank you, sir. Thank you. On behalf of ACVR, I would like to thank first of all Alka Agarwal ma'am for associating UPIP with the ACVR to conduct this third neurodisability, and we are really appreciate her concern and her commitment about the neurodisability. I would like to thank Rasmi Kumar ma'am, who she has spared her valuable time for this conference, and she is always there, and she is the chairperson of this ethical committee of ACVR as well. Dr. Niranjan sir is the guiding force for all of us, and since beginning he is supporting and guiding. Thank you, sir. Thank you for joining. I am thankful to Dr. Maramba and Dr. Venkat Reddy sir, Dr. Ujaina, and all the research scholars, as well as all the attendees of this program who has given their precious time. And at the last, I am really indebted for the hard work and dedication of Dr. Rahul, who tirelessly working for this noble cause and ultimately succeeded to develop digital solution of the neurodevelopmental problem. Thank you once again to all of you. I think we should wind up, Dr. Rahul.
Yes, I think we should wind up. And on the platform, if there's any questions, you can leave on the conference, on the public forum, and we'll be happy to answer. Thank you all. Bye-bye.